Good afternoon, everyone.
Good afternoon.
All right, we are gearing up for today's meeting. We will give everyone about 6 or 7 minutes to jump on, and then we'll begin.
Turn this volume down a little bit. Yes. Yes.
Okay, good afternoon again, everyone. It looks like it is 2 o'clock on the dot, and we will go ahead and begin this afternoon's meeting of the Louisiana COVID-19 Health Equity Task Force. I'm Katara Williams, Chief of Staff here at Southern. I want to welcome you all back. It's been a couple of weeks, but we are certainly glad to gather, and we've been doing such great work in the interim, and we are very fortunate today to have a very special guest to talk about the important work that we've been doing and the important work that's being done across the state relative to COVID-19. Before we begin, let's go ahead and start with our roll call. Ms. Gerald?
Yes, good afternoon. Dr. Sandra Brown,
Here.
Dr. Thomas Leviste,
I'm here.
Dr. Thomas Leviste,
Here. Do you not hear me?
Dr. Ray Belton, Dr. Kimberly Hunter Reed,
Here, Victor Jones on behalf of Dr. Reed.
Secretary Robinson, Dr. Adrian Wilson, Dr. Katara Williams,
Good afternoon, I'm here.
And Secretary
Terry
Kimberly Robinson
Sterling.
is here with me, Tracy.
Hold on one second. Hold on one second.
Secretary Robinson is here. She's with me. She's just not on the screen.
Miss Sadie Finkel,
Yes, I'm here on behalf of Councilmember Helena Moreno.
Dr. Victor Jones,
What'd you say, Jeremiah?
Mr. William Bowles, Miss Megan Muncy, Dr. Mary Meg Brown,
Here.
Dr. Renato Banks, Senator Regina Barrow,
Here.
Dr. Terry Davis, Dr. Rebecca G., Miss Tiffany Netters, Miss Carol Smith, Dr. Ronnie Whitfield,
Present.
Dr. Gary Wilkes,
Here.
Dr. Damian Ejigiri,
Next.
Dr. Eric Van Hoom,
I'm here.
Ms. Delicia Alford,
Here.
Dr. Tavell Kendall, Representative Dustin Miller,
Here.
Ms. Alma Stewart, Mr. Christopher Tyson, Dr. Derek Rovares,
Here.
Dr. Corey Hebert,
I really do want to move.
Ms. Lenore Corolla, Dr. Keith Ferdinand,
Here.
Councilwoman Helena Moreno.
Sadie Finkel representing Helena Moreno.
Yes, ma'am. Councilwoman Cindy Nguyen, Dr. Bates, Dr. Janine Thomas,
Here.
Dr.
Bates
Leah
is here.
Fowler,
Here.
Miss Cindy Snyder,
Here.
Miss Kathleen Tate, Dr. Lisa Van Hoos,
Here.
Miss Shalina Davis,
Hey.
Mr. Michael McClanahan,
Here.
Dr. Connie Arnold,
Here.
Dr. Faye Grimsley,
Okay.
Miss Erica Rogers, Mr. Frederick Thomas, Dr. Demetrius Porsche,
Here.
Miss Judy Reese Morse,
Here.
Dr. Earl Nuptius Benjamin Brown,
Here.
Dr. Peter Fox,
Here.
Dr. Kathleen Kennedy,
Here.
Why is she
Dr.
still?
Robert Maupin,
She may not know her phone is muted.
Tracy, we don't hear you anymore. You're muted.
wow. Okay, sorry about that. Dr. Robert Maupin, Dr. Christy Anderson,
Here.
Dr. Takesha Davis,
Here.
Dr. Amanda Dumas,
Here.
Dr. Amy Leeson, Dr. Ebony Price Haywood,
Here.
Mr. Raymond Jetson,
Here.
Dr. Margarita Echeverry, Miss Christian Engel, Miss Tina Granger, Miss Catherine Haywood,
Here.
Reverend Theron Jackson,
Here.
Mr. Rudy Macklin, Dr. Orlando McMeans, Dr. Rhoda Reddix, Dr. Simone Rimbadi, Dr. Jacqueline Harris, Dr. Peter Kasmarsky,
I'm here.
Dr. Daniel Sarpong. Is there anyone that I did not call that's on the call today?
Rhoda Reddix.
Got you.
Faye Grimsley.
Alicia Bates.
Okay. Anyone else?
Amy Feehan, I'm here.
And Christy Reeves with Oshner.
Okay. Dr. Brown.
Thank you. It is my distinct honor and privilege to introduce our special guest today, Governor John Bell Edwards. We thank you, Governor, for meeting with the task force and for your commitment to improving health equity for the citizens of Louisiana. On behalf of my co-chair, Dr. Levine, and the task force members, we welcome you. We also would like to welcome Dr. Amy Feehan, who is the principal investigator of Oshner COVID-19 prevalence study in Baton Rouge, Christy Reeves, Vice President of Community Affairs, Oshner Health System, Dr. Teresa Sokol, Assistant State Epidemiologist for LDH, Dr. Alex Viu, Assistant Secretary of Health, LDH, and Dr. Joseph Cantor, Assistant State Health Officer for the Greater New Orleans Area, LDH. So, Governor, we welcome you.
Thank you very much. I appreciate that, Dr. Brown, and I appreciate you for inviting me to address the meeting this afternoon. I do start off by wanting to convey to you my hope that all of your families and you are safe and healthy. There are a lot of challenges out there, COVID being principal among them, but there's some weather challenges too that I'll talk about in just a minute. Also, I am extremely thankful for the work that you all have done and are doing, and I know are going to continue to do on this task force, which is critically important. We first announced this group on April the 24th, and I recognized immediately that we were bringing together the absolute best professionals from the state of Louisiana in a bunch of various fields, but principally a lot of healthcare experts. And after the roll call, I realized I'm the least educated, least smart person on this call when I saw who was participating. So I have some idea how valuable your time is, and the fact that you're willing to spend a lot of that time and put forth the effort that you're making to improve health outcomes in Louisiana. I just want you to know I very much appreciate it. And I especially want to thank Dr. Sandra Brown, the Dean of Southern University's College of Nursing and Allied Health, but also Dr. Thomas Leviste, Dean of Tulane University, School of Public Health and Tropical Medicine. As you know, they are the co-chairs of the task force. And then, of course, we also have co-chairs of the 9 subcommittees, each of whom produced a report. So a lot of work going on. Thank you. And a big part of this call is to make sure you know that we are incorporating your work into what we do as we continue to respond to this pandemic caused by COVID-19. As you all know, we were the first state in the nation to report data on cases and primarily on deaths that showed the disparate impact of COVID-19 by race. And this task force was formed shortly thereafter. And I want you to know that in the intervening months, the data is coming in, and it's not as elevated as it was before. And given that the first time we announced, I think close to 70% of all COVID-19 deaths were among African Americans, even though African Americans comprise only 32% of the state's population. However, the number of cases within the African American community and certainly the number of deaths still far exceeds the percentage of the population that is comprised by African Americans. And we've also started to see over the last several months real disparate impacts of this disease on Latinos. And so really it's people of color who are disproportionately impacted. And that is not to say that Caucasians are immune and haven't suffered a lot of cases and a lot of deaths, but the cases and the deaths don't represent their percentage of the population. But having said all of that, the work that you're doing is going to beneficially impact everybody in the state of Louisiana, regardless of their race, because that's just the nature of the work that you are doing. You know, we created the task force to provide recommendations relative to the health inequities that I just spoke about, those communities of color. And I tasked you with a set of goals back in April, and there were 3 principal goals: providing reliable and data-driven information on COVID-19 safety and prevention. Secondly, providing the medical community with best practices and protocols for treating communities with underlying medical conditions and health disparities. And thirdly, ensuring testing availability and ease of access for all communities, especially those most impacted. And what I appreciate about this task force is you went to work immediately and you produced results that informed our response to COVID-19 and that continues to inform our response. The work on the subcommittee on COVID-19 testing for vulnerable and at-risk communities was a part of the statewide testing plan that was developed by the Louisiana Department of Health and submitted to the federal government for approval and for funding. Your recommendations or insight are impacting the improvements that have been made and the data that is available on the LDH website as well. The subcommittee on data and analysis included a quote from the Robert Wood Johnson Foundation in their report. An important consideration in establishing a public health or surveillance system related to COVID-19 that's able to collect, analyze, and report data that is disaggregated by age, race, ethnicity, gender, disability, neighborhood, and other socio-demographic characteristics. We're working to ensure our public health surveillance system and data collection are meeting these recommendations. I've asked LDAs to join me, and I know that Dr. Brown mentioned many of those individuals just a moment ago, but they're joining me today. They're going to discuss this data with you. Dr. Teresa Sokol, the state epidemiologist, she's with us. She's going to walk us through this information once that I'm done. Your recommendations on nursing homes will continue to inform our work. You know, like many states across the country, we have seen a tremendous percentage of our deaths be in nursing home settings. And quite frankly, the virus, I believe, seeded deeply in many communities across the state of Louisiana before anybody knew. It got into the nursing homes, I should say. And that continues to be a problem because anytime you have a significant degree of community spread, it is very, very difficult to keep the virus out of the nursing homes, given that staff come and go every day. And so we're continuing to do a tremendous amount of work focused on sanitation and cleaning, those types of protocols, but also on 100% testing of residents and of staff. And most recently, we received a recommendation from CMS this past Monday that we start testing staff in nursing homes twice a week. That is a daunting challenge, and certainly one that has a fiscal impact as well. But you all have been working on testing protocols for staff and patients, and much of that is currently in place. You should know that the federal government is in the process of sending rapid point-of-care testing machines to nursing homes across the country, and that includes 9 here in Louisiana that have already received them, 7 traditional nursing homes, and 2 of our war veterans homes. And obviously, this is just the start. Over the next several weeks, the plan from the federal government is to send one of these point-of-care devices to every nursing home in the country. And if we have the devices and the expertise to use them, the knowledge on how to use them, and the testing cartridges that we need, that should be very, very helpful in testing residents and staff. And one of the things that could potentially happen from this is down the road, as we are able to do it, the point of care testing can be used to allow safely some very limited visitation to residents of nursing homes who haven't been able to participate in visitation with their loved ones in some while. Now, there's a recommendation from CMS that a nursing home have 21 days free of virus before we would consider that, and that we have the ability to do that rapid testing. So we're not there yet, but that's something that hopefully we can get to in the not too distant future. Your subcommittee should send any recommendations on rapid testing and visitation through Dr. Brown and Dr. Leviste. Your work has also included partnering with the Resilient Louisiana Commission on their report, which is due out in the coming weeks. It also included partnering with Ochsner to look at the prevalence of COVID-19 in the Baton Rouge area. And in fact, the Health Equity Taskforce helped fund that study. Christy Reeves has already been mentioned, but with Ochsner, they really put that effort together with some help of other funders and Pennington Biomedical that did some of the research. You're going to hear from Dr. Feehan shortly about the results, but the results were announced yesterday. And what we did is in Baton Rouge, and not just in Baton Rouge, but in the 5 parishes here in the capital region, we looked at the prevalence, I should say, of COVID-19. And the results of this area study were announced yesterday, and Ochsner will lead you through that in just a moment. Again, Dr. Amy Feehan, Christy Reeves will speak after Dr. Sokol. But let me just say that it was a sobering briefing that I attended a couple of days ago when I got a sneak peek at the data. there are multiple lessons learned and insights gained from the study, and we certainly don't pretend that we know everything we want to know, but two things that became very, very clear. Achieving herd immunity through virus exposure is a suicide pact. It's not a public health strategy. Just given the number of people that would have to contract the virus to develop the antibodies, somewhere around 14 or 15 times the number of people who've already contracted the disease. And you know that we've had 4,500 deaths. We've had tremendous challenges in our hospitals and so forth. So that's not a strategy. But the biggest lesson for me was that in the Baton Rouge area, and this is not a small study, 2,100 adults were tested both for antibodies and for the virus. 60% of those with the virus were asymptomatic. 60%. That scares me. It should scare anybody, whether you're a public health professional or a medical professional, whatever. It should scare anybody who knows anything about this disease, because 60% of our people with it aren't symptomatic, almost certainly don't get tested then. They don't know they have it. And unless they adhere to the mitigation measures we put in place, like masking and social distancing, then we know that they are contagious, even though they're not symptomatic and they're out spreading. So that concerns me tremendously. But before I turn it over to the doctors, I want to be clear that this is not our last meeting. It certainly isn't the end of your work. But I did want to reassure you that your work has been invaluable, and I look forward to continued engagement. The recommendations from the subcommittees on community outreach and stakeholder engagement, communications and messaging, and the health equity dashboard certainly are going to require ongoing implementation. I also understand that you've identified some next steps for consideration, and it is my hope that you will continue the level of engagement that you have shown thus far. So I'm looking forward to your continued work and the impact you're going to have on access to high quality medical care and improved health outcomes. Two more quick subject matters. The first is a short while ago, the LDH released today's report on numbers. The number of new cases reported is 1,093 on 19,773 tests. By the way, we should test somewhere between 500 and 600,000 people in the month of August. That will be 2.5 to 3 times our monthly goal of 200,000. The total number of cases right now are 141,720, and we have administered from the beginning more than 1.7 million tests. Very sadly, we're reporting 50 new COVID deaths today. Also, we have 17 more people in the hospital than yesterday and 6 fewer on vents. So that messaging is a little bit mixed, but we dropped 200 in the hospitals just over the previous 3 days. So I'm not overly concerned about an increase of 17 today. And the positivity numbers continue to go down across the state, so that the state average is less than 10% for the first time in a long time. And positivity is the earliest indicator of what we can expect. And so long as those numbers continue to trend in a positive direction, which means downward, then hopefully we're going to be okay. The challenge for us is we have more mobility in Louisiana today than we've had in a long time, with a lot more people coming into contact with one another, because our K through 12 schools are reopening in the month of August, and also because of our higher education campuses reopening as well. So we have to watch things very, very carefully. Finally, the reason I'm going to have to leave here very shortly is because we have 2 storms approaching our part of the world, one of which is already named Laura. The other should be named Marco pretty soon. They both have a cone that extends into Louisiana. And they're both expected to hit, make a landfall at some point early on Wednesday as hurricanes. And so this is the very first time in history that we've had two storms forecasted to hit at the same time in the Gulf Coast as hurricanes, and the cones of these two storms actually converge in Chauvin, Louisiana. So it's my hope that that doesn't happen, but I'm going to continue to prepare for it. Should it happen, one or both of those storms actually make a landfall in Louisiana. And I invite you to join me in praying for the best, both as it relates to the weather and the storms and natural disasters on the one hand, and then COVID-19 on the other. So thank all of you. You've got some good information coming your way right now on data from the Louisiana Department of Health and Dr. Sokol. And then after that, with the briefing you're going to get on the Baton Rouge prevalence study. So again, Dr. Brown, Dr. Levice, thank you so much. God bless you. I really, really appreciate the work that all of you all are doing. And it is making a difference. So God bless you. Stay safe out there, both from the disease and from any natural disaster. So thank you, Dr. Brown.
Thank you, Governor. And today we make you an honorary expert.
Yeah, well, thank you. I appreciate that.
Thank you. At this time, we would like Dr. Katara Williams to give us an overview of how it relates to public.
Yes, thank you, Dr. Brown. And of course, thank you, Governor, for your leadership as always. Just so that everyone knows, this is, of course, I want to remind you, this is a public meeting. Therefore, we do have staff standing by to receive any public comments. They can be emailed to public_comments@sus.edu, or you can call in your comment at 771-4364, area code 225. You can also log on to our website at sus.edu and click on Louisiana Health Equity Task Force and submit your public comment there. Dr. Brown?
Thank you. At this time, we will invite Dr. Amy Thiam, Principal Investigator of Ochsner COVID-19 Prevalence Study. Dr. Thiam?
Hi, I'm going to share my screen. Okay, can everybody see that?
Yes.
Okay, great. So yeah, I'm very pleased to present the findings from our Baton Rouge prevalence study, and thank you so much for helping us fund this important work. This is a list of some of my co-authors on the papers that we're getting ready to put out, but hundreds more people helped with this project. So just a quick thank you to our funders. So to get everyone on the same page, the goal of this study was to determine the spread of the virus across Baton Rouge. So we recruited adults over the age of 18 and tried to create a mini Baton Rouge, so matching by demographics like age, race, ethnicity, and neighborhood. And so I'll explain this a little bit more later, but people who had already tested positive were not eligible to enroll in the study. Those who did enroll, though, were sent a text message to go to one of our testing locations where they were consented to participate in the study. They took a short survey and then received both the nasopharyngeal swab, or the COVID test, and a blood draw for an antibody test. So we did test over 2,100 people, and they all had to be residents of Ascension, East Baton Rouge, Livingston, or West Baton Rouge. And this testing took place for the last 2 weeks of July, the 15th through the 31st. So the disease progression is kind of the reason that we picked these two tests to kind of complement each other, was that at time 0, when you're infected with the virus, you start to show you would start to test positive on the nasal swab test or the PCR test. And then this blue line kind of shows the course of the viral infection. Meanwhile, at some point, your body starts to generate antibodies to the virus, and that's represented by this red line. When antibody starts to be detectable, and then, you know, after the virus is cleared out of the system, you have antibody remaining in your blood. So that kind of splits this into 3 groups. So this group that would be testing PCR or swab positive, but antibody negative, those are the contagious people. So they're infectious at that point. And then this group that's kind of overlapping, once you have antibodies showing up, you're thought to really not be infectious, even though you would continue to test positive on that PCR or swab test. And then once the virus is gone and you just have antibodies left over, this is the recovered phase of the disease, or convalescent is another word that people use. So from our raw data, the numbers broke down like this. And just as a reminder, we're only looking at people age 18 and older for this study. So that's all that we're projecting to in the larger Baton Rouge population. So the population in these 4 parishes that's over age 18 is this number here. And so you can see in the raw numbers from the study, 2.9% were in that contagious category. 1% was in that middle, like recovering late stage infection category, and 2.2% were in the convalescent or recovered phase of the disease. So if you project these numbers onto the population, that's nearly 16,000 people walking around with an active contagious infection. And of those, and Governor Edwards mentioned this, 61% were asymptomatic, which is almost 10,000 people walking around with absolutely no signs or symptoms that they have this virus. And then you can kind of see the breakdown and the projections in the later 2 stages of the disease as well. So this first map, we separated everybody by zip codes and then looked at that contagious infection over total tests for each zip code. So what you're looking at is a heat map of where contagious infections were most prominent. And the more prominent, the darker the color of the zip code. So all of these little green dots were our testing locations, which were rotated. We weren't operating all of these all on the same day, but tried to make them available to the bulk of the community members here. So you can see that infection status ranges from like 0 to 0.8%, all the way up to, in one zip code, was closer to 40% infection rate. In the zip codes that are hashed out, we had fewer than 10 participants from those zip codes. So we just didn't want to make any far-reaching claims about percent positivity when there maybe wasn't enough participation from those areas. And then the second map that I'm going to flip to includes testing positive on any test. So it's going to get a little bit darker, but that includes anybody who has passed their infection too, just to give you an idea of the areas that have been the hardest hit cumulatively over this time. All right, so this is a lot of information, but I'll guide you through it. So this first column represents anyone who tested positive on either test or both tests. So this was any infection, past or present. And then down the left side, it's broken down by race or ethnicity, and then also by parish. In this column, we have current infections. So those are those contagious infections where you're testing positive on the PCR test, but not on the antibody test. And then this grouping is the late stage infections and prior infections. So anybody who tested antibody positive falls into that category. And then here we have just the projected number of infectious people within each of these subgroups. And that's based on this percentage and the number of people in those subgroups who are 18 plus in the Baton Rouge area. So a couple of things to notice. First of all, our overall infection rate, and these are, by the way, census adjusted numbers from our raw data. But the overall infection rate was 6.6%. The contagious infections were 3%, and then past infections 3.6%. So a couple of things to notice, just like in our New Orleans version of this study, there were racial disparities as far as any infection testing positive on either test. And so you can see that for white and Asian residents, they were about half there was about half the prevalence of Black or Hispanic participants. However, if you look at current infections, that disparity kind of goes away here, but there's obviously a lot of current infections in the Hispanic or Latino communities. And it makes sense then that early on in the pandemic, Black or African-American residents were hit hardest. And so one other thing we noticed here is that in Livingston and West Baton Rouge Parish, it's kind of concerning that there are a large percentage of contagious infections at the time of this study. Okay, so I know all of you are doctors of varying degrees, but just to make sure everyone's on the same page, these are odds ratios. And so when any of these error bars cross the line at 1, that means they're not significant. So I've highlighted the significant ones in blue, and we're comparing the comparator on the left to the comparator on the right. And so I'm just going to go through the ones that are significant. So if you were Black non-Hispanic, you were 3.2 times more likely to test positive versus white non-Hispanic. Hispanic of any race, you were 2.7 times more likely to test positive relative to white non-Hispanic. And then the younger individuals were much more likely to test positive versus that 70 plus group. And the 70 plus was pretty similar to the 40 to 69 groups. So you don't work with Pennington and get away with not looking at BMI. And so we did include that. And actually, and I'm going to show you some other comorbidities in just a second, but BMI did not actually influence whether you caught the virus, which is what we're looking at here. But clearly it affects outcomes once you're, on the other side of catching the virus.
Can I just chime in for 1 second and emphasize the point on that slide, especially
Yes.
for the communications subcommittee, that this showing that, this message around young people and young people being immune and which we hear in the media, this right here, I think once again shows just how important it is that we start to really message to young people about just how, because the young people are more likely to be infected, right? So they are more contagious and they may be even greater risk. So this messaging to young people that they need to be particularly diligent, that they are at risk, is really important. And I think we all need to, as we go out do our work, we need to be messaging around this to make sure that young people start to understand this.
Especially as colleges start opening, right? Yes. Yeah, for sure. Okay, so just as a quick pit stop summary slide. So our finding was that 6.6% of the population had been infected, or of the sample at least had been infected at the time of the study, which we project to over 36,000 infections across the population. Because we excluded anyone who had a previous positive test, you can actually just add that number to the state reported cases for those 4 parishes, which was, as of August 2nd, it was just over 17,000. So when you put those together, the total prevalence is 9.7%. So still under 10%, like Governor Edwards was saying, very far away from herd immunity, which I think everybody in this audience probably realized. And so also that first infectious group, we estimated that more than 16,000 residents were walking around with a contagious infection at the time of testing. And of those, 10,000 of them had no symptoms, which is that 60% rate listed here. So just like New Orleans, prevalence was higher among minorities, particularly Black and Hispanic residents, and higher among young people. Okay, so more odds ratios. As you can see in the top panel, everything was significant. If you had a symptom of any kind, you were more likely to test positive. However, this anosmia, or the loss of smell and taste, was very distinctive. So essentially, like, you have fever or dry cough or whatever, and you could have those for reasons other than COVID. But it really seems like anosmia is kind of a standalone symptom of this disease. So you were actually 8.5 times more likely to test positive if you reported that symptom. And this too, like, I'm sure many of you know, it's a very stark symptom. It's not like you have allergies and something kind of tastes funny or you can't quite smell right. It's like gone. Your sense of smell and taste are, it's been described as like drinking whiskey and it tastes like water. So that's a very striking thing that we also found in the New Orleans study. Looking down the list of comorbidities though, and just like BMI, these really didn't influence whether you caught the virus, except if you had no comorbidities. And this is one that we did not find in the New Orleans study, but actually here, and you can see there's just a little bit of a white line between there. You were 1.5 times more likely to test positive if you did not have comorbidities. All right, so this is kind of grouped weirdly, but the first three are looking at marital status. Single people were almost 2 times more likely to catch the virus versus married people, and divorced and widowed were kind of in the same ballpark as married people. And then we have the work status is grouped here. So this 50-50 group is people who are going into work part-time and working from home part-time. And this includes people who either were working from home at the beginning of the pandemic and now are starting to go back into work, or people who are, you know, like going in 2 days a week and working from home 3 days a week. Anybody in that whole group.
Can I ask?
Yes.
Are these just bivariate relationships? So like, for example, are these age adjusted? So like marital status?
No, they're not adjusted. So we're going to do a deep dive on a lot of different stuff. But this was just high level, just comparing these 2 factors.
Mm-hmm.
Yeah. So the other grouping here, unemployed, laid off, or retired, we grouped those all together. 100% going into work, 100% working from home. And the standout here was that you were 2.3 times more likely to test positive if you were 100% going into work versus like this 50-50 group, which was similar to the working from home or unemployed group. And then actually office workers showed the lowest prevalence of any of these job types. So we compared all of the other job types to the office workers and found that public facing jobs were over 3 times more likely to test positive. Delivery or door-to-door were much more likely to test positive, although this sample only contained 14 people. So there's kind of a caveat there. And then healthcare, whether you were in direct patient care or not, 2.6 times more likely to test positive. And this other group was 3.3 times more likely to test positive. So if you thought you had COVID, you were twice as likely to actually test positive. And if you had a positive family member, you were more likely to test positive. So this did include, this calculation included some weighting. So here's the actual number breakdown of who identified as these different job types or job environments within the study. So I have these ones grayed out. They're kind of a smaller number, so, you know, taken with a grain of salt. But this is the weight, this prevalence for each job type is weighted by how many of each group was doing any of these work environments. So they're weighted by each other, but still you can see kind of stand out as the public facing job and the other category. And then if you were mostly or completely going into work, you're close to like 9% prevalence. However, office workers and people who were going into work part-time are closer to 3 to 4% prevalence. So there might be some like protection there. So just to summarize these last slides, any symptoms were associated with higher odds of testing positive, particularly anosmia. People without comorbidities were more likely to test positive. Office workers had the lowest prevalence of any job type, and single people were more likely to test positive. So I guess the takeaways here, mostly I'm sure the gears are turning for all of you, and happy to take questions, but just as Governor Edwards emphasized, the lack of symptoms in over half of people who tested positive is pretty scary, and just really reemphasizes the fact that masks are a necessity. And that if you're feeling fine right now, you still have no idea whether you have the virus or not. So I guess with that, any questions?
Thank you, Dr. Feehan. We'll open it up for any questions briefly.
Will these data be made available?
Yes, we're working on publishing them and more of them.
No, I mean the actual data, not the results. Will we be able to do our own analysis of the data?
I'm not sure. I'd have to go like back to my working group and find out if we could do something like that. I'm personally happy to work with you on any kind of analysis.
Well, I'm thinking, I'm thinking more. We have a subcommittee on data, and I think it'd be great if we can make this data available to that subcommittee.
Okay, yeah, I can look into that and see if that's something we can do.
That subcommittee is Dr. Rambiotti is leading that subcommittee. So we'll definitely connect you two.
Okay.
we can do with that. Vice President Christy Reed, did you have anything you wanted to add?
No, not really. Mostly, we wanted to thank this group for investing in this study. And, I think that hopefully you'll see that there's a lot of things that we didn't know, and there's some things that are frightening. We're trying to work through at Ochsner, how do we respond to this? Clearly, the role that I have at Ochsner is focused on community outreach programs in response to this type of work. And so as you continue your work, we'd like to be part of that conversation. We know that we have representation on that. And we hope that this will guide your work. So we just thank you for the opportunity to do this. It's just such a critical, not knowing so much about the disease, it really helps us understand the virus better. So thank you.
Thank you. There's a chat. In our chat, they're wanting to see your very last slide, Dr.
Oh, sorry, I just stopped sharing it. Okay, so I'm guessing not this one. Was it this one?
Yeah.
Or, okay.
This is the takeaways.
Yes. Okay.
So it emphasizes what we've been emphasizing all along.
This group already knows most of it. It's just, at least it's some really rich data to point to and say, this is why we're doing what we're doing, and reinforce it.
Thank you so very much for sharing the preliminary results that you have.
Yes.
And we look forward to hearing more as you take a deeper dive.
Yes, definitely. Thank you so much.
We have Dr. Teresa Sokol, our Assistant State Epidemiologist from LDH. You on the call? Okay. Dr. Oh, there she is.
Okay. Are you able to see my screen?
Yeah, thank you.
Okay, great. So good afternoon, everyone. My name is Teresa Sokol. I'm the acting state epidemiologist and the program director for the infectious disease epidemiology section of the Louisiana Office of Public Health. I'm very happy to be here today to provide an overview of COVID-19 race data that's been collected by LDH, and I'm hoping that it can help inform the important work of this task force. So thank you very much for the invitation to be here today. So I'd like to first just provide a quick statewide update about COVID-19 in Louisiana. As Governor Edwards said, we're reporting a cumulative total of 141,720 cases today. And as you can see in this epidemic curve, which displays the number of cases by date, we experienced a steep increase in cases after moving into phase 2. But we're currently experiencing really a clear decline in cases since the governor enacted important mitigation measures, including that statewide mask mandate last month. However, it's really important to keep in mind that we are still experiencing high levels of COVID-19 transmission throughout the state, and you can see that in the graph on the next slide here. So this is a graph of the total number of new cases per 100,000 people over a 2-week period, or what's referred to as a 2-week incidence. And so as I'm sure most folks on this call know, epidemiologists calculate the occurrence of new cases according to a unit of population, so that we're able to compare the rate of new cases across different communities with varying population levels. Now, CDC has established categories of COVID-19 incidents, and these are either high, moderate, or low, and you can see the legend there just to the right of the Louisiana map. As you can see, despite the recent decline in cases, every parish in Louisiana still has a high incidence of COVID-19. This means that there is a high level of transmission that is occurring throughout our state. So we all need to remain vigilant and dedicated to prevention measures such as social distancing and wearing masks. On this slide, you can see a graph of COVID-19 deaths by date of death. Now, there's a time lag between when you're going to see an increase in COVID-19 cases and then a corresponding increase in deaths. And this is because of the time between when a COVID patient first becomes ill and then when they ultimately die. Because of this lag, we are currently still seeing an increase in the number of deaths that are occurring despite the reduction in new cases. As of today, I believe Governor Edwards mentioned this as well, the cumulative total of COVID-19 associated deaths in Louisiana is 4,546. On this slide, you can see a graph of COVID-19 deaths, you can see the breakdown of cases and deaths by race. Now, let me just first say that collecting race data for cases is really challenging, particularly for a state like Louisiana that has as many COVID cases as Louisiana does. Now, because it's really important for us to characterize and understand, especially the severe health outcomes related to COVID, we have a team of epidemiologists that collects and reviews medical information for each COVID-19 associated death that occurs in Louisiana. Now, unfortunately, as I'm sure you can all understand, this level of detailed review is just unable to be conducted for each of the more than 140,000 cases that have been reported in Louisiana to date. So unfortunately, the race and ethnicity data that are submitted with each case report through our electronic laboratory reporting system is usually incomplete for more than half of the case reports that we receive. However, our Bureau of Health Informatics team within the Office of Public Health has developed a process whereby they are able to collect race data for the majority of cases for whom this information was originally missing. So as a result of their excellent work, you can see now that the proportion of cases for which race is unknown is now only 11%. And that's honestly really quite low if you compare it to what many other states are reporting. So if you're looking at cases, other than the 11% of cases for whom race is unknown, 38% are Black, 37% are white, and race is reported as other for 14% of cases. Now, this includes individuals identified as Asian, Native Hawaiian Pacific Islander, Native American, Alaskan Native, and also for whom individuals for whom race is specifically listed as other. There's no other category that's provided. Now, because of the detailed review process for deaths that I mentioned earlier, race is unknown for fewer than 1% of deaths. We really have very, very complete information regarding race as it relates to the death. Now, 1% of deaths are among individuals whose race is listed in the other category. Other than that, 48% are Black, 51% are white. And if you compare these proportions to the overall race demographics of the statewide population, it does appear that there are a disproportionate number of cases and deaths among Black individuals compared to white. This next slide displays cases and deaths by ethnicity. For both cases and deaths, the proportion of unknowns is higher for ethnicity than for race. We use the same process to try to collect additional information, but it's just often unavailable. Ethnicity is unknown for 35% of cases, and then 60% are identified as non-Hispanic and 5% are identified as Hispanic. Among deaths, 6% are unknown, 92% are non-Hispanic, and 2% are Hispanic. So the next few slides, we're going to look at some additional details related to race and COVID-19 associated mortality. So as you can see from this table, which details underlying medical conditions among individuals with COVID-19 associated deaths, a higher proportion of Black individuals had underlying hypertension, diabetes, chronic kidney disease, and obesity compared to whites. Now you can see that if you were to sum the percentages listed for both groups, it would total more than 100%. And that's because many individuals had more than one underlying condition reported. So we wanted to look at that in a little bit more detail. So if you look at this slide, you can see that this graph displays the number of underlying conditions reported for individuals that died from COVID-19 associated deaths. The number of Black and white individuals with either no or one underlying condition are fairly comparable, though slightly higher among white individuals. However, there are more Black individuals that have two or more underlying conditions compared to whites. You can see that that is true for individuals for the number where the number of underlying conditions is 2, 3, 4, 5, or more. For all of those categories, the number is higher among Black individuals than white individuals. This finding likely speaks to important health disparities that exist between these groups in Louisiana. In addition, I'd like to point out that the average age of Black individuals who die related to COVID-19 is 9 years younger than white individuals. This final slide highlights data related to multisystem inflammatory syndrome in children, or MIS-C. So now this is a condition where different organ systems can become inflamed, and this includes the heart, the lungs, kidneys, brain, gastrointestinal organs. Now, children with MIS-C, they have a fever and other various symptoms, which often includes abdominal pain. For most of our cases, gastrointestinal symptoms are present, including vomiting and diarrhea. It can also include neck pain and a rash and really feeling extra tired. Now, MIS-C is a severe illness. It requires hospitalization. The MIS-C cases in Louisiana, in fact, have been hospitalized for an average of 7 days. Now, while we don't yet know specifically what causes MIS-C, we do know that many children with MIS-C had been infected with COVID-19 or had been around someone with COVID-19. Now, MIS-C is a post-infectious process, and that means that it takes some time, usually 2 to 4 weeks after a child is infected or exposed to COVID-19 for them before they develop symptoms of MIS-C. This means that, like the deaths, increases in MIS-C cases will lag behind case increases. So as a result, we're currently seeing an increase in MIS-C cases despite the current downward trajectory in new cases. Currently have a total of 57 MIS-C cases that have been reported. And as you can see in this table, 40% of these cases have been among Black children, 32% among white children, and 3% among Asian children. In addition, 32% of the MIS-C cases have been among Hispanic children. Among these 57 MIS-C cases in young people, unfortunately, 4 deaths have been confirmed. Thank you very much, and I'm happy to take any questions that folks may have at this time.
So we'll open it up for any questions for Dr. Sokol. Will these slides be available, Dr. Sokol, to share among the committee?
I'm sorry?
Will your presentation be made available to provide to the committee?
Oh, I'm certainly happy to share it.
Thank you. Okay, I'm not sure if Dr. Bu was on. He might have left with the governor. Dr. Bu, are you on? We'll move on to Dr. Joseph Cantor. He is the Assistant State Health Officer for the Greater New Orleans area for LDH. Dr. Cantor, would you like to share any information with the committee?
Hi, thanks for that. I actually don't have a separate presentation. Teresa covered the data that we have, but both Teresa and myself are available for any questions or discussion if there are any.
Hey, Dr. Brown, this is Earl, Nutrition Benjamin Robinson. I just want, since I work at LDH, I've been examining and had the pleasure of working alongside Teresa and her team. And I just wanted to say thank you to her and all the work that she has been doing to help ensure that, you know, we get the information that we need, and we are looking at the nuances of the data. So I just appreciate everything that she and her staff, Dr. Ali Mendoza and the others have been doing in getting information and sharing information with us to inform how we make decisions. So just a job well done, I want to say, to Teresa and her team for all that they've been doing thus far as it relates to data collection and sharing of data.
Thank you. Thank you so much. Okay, there are no questions. We'll move on to the introduction. It's my pleasure to introduce Secretary Kimberly Lewis Robinson. She serves as the Secretary for the Louisiana Department of Revenue, and she has been instrumental in facilitating the work of the task force. Although her expertise is in tax and revenue, she is quickly becoming an expert in health disparities. So Secretary Robinson, can you provide us with some insight into next steps, brief summary?
Good afternoon, Dr. Brown and Dr. Levice. And thank you to the Health Equity Task Force for having me. As you heard from the governor, he does not think that your work is done. And I know that I've heard from the co-chairs that they are thrilled to continue working. Yes. Actually, I know that there are some ongoing projects related to communications and messaging. And as I think the last slide in the Ochsner prevalence study showed, masking and hand washing and the things that we've been talking about from a communications and messaging standpoint, making sure that especially young people know the importance of wearing a mask, staying socially distant, getting that messaging out is very important and something that we have to continue working on. And there were lots of recommendations in the subcommittee reports that do require ongoing work. And so that is something that we will continue with the implementation of in the coming weeks and months. I did speak with Dr. Griggs on yesterday about finalizing his contract so that he can finish the video production work for the Communications and Messaging Task Force, as well as getting some additional work, if necessary, to get the message out that we want to get out. And also had some conversations initially with Secretary Phillips about the health dashboard, since that will require ongoing work on the part of the Department of Health, as well as the Office of Technology Services to maintain that dashboard. While we start with a product, if we want to continue that product, it must be maintained, the software and licensing maintained by the state once we put it in place. And it's wonderful that Dr. Benjamin is up on the screen, since that would be within his area at LDH possibly, as far as where that dashboard would continue to be maintained. So those are some of the ongoing things that come out of this task force. And I know there are some next steps that have been discussed and identified. So I think as we continue to lay out what those next steps look like, the work of the task force will continue. And that includes some policy recommendations that have been made. And some of those policy recommendations flow into some of the recommendations that come out of the Resilient Louisiana Commission. And I know I saw that Terry Sterling, who's the co-chair of that commission, was also on the task force meeting today. I saw her window pop up when we were signing in. So those two groups together would continue to make some recommendations that hopefully come out in legislation. We actually had a few recommendations on some of the things that were in the policy proposal, including nurse practitioners being able to practice independently and provide better access to healthcare around the state. The suspension of those requirements during the pandemic have been one of the things that have allowed for expansion of some of the licensing of nurse practitioners in some of the rural areas. And as we've looked at the impact of the current surge in caseload around the state, when we started the pandemic, most of the cases were in Region 1 in New Orleans. Right now, we have cases around the state. And I think as of yesterday, there were 16 hospitals that did not have ICU bed capacity and maybe 12 that didn't have med surge capacity. So knowing that we need additional medical capacity around the state is something that is very important. And the fact that the revenue secretary now understands what med surg capacity is a scary thing. So I know that some of the recommendations that have been made about what we need from a healthcare standpoint and expanding healthcare access is critical. So the work of this task force and the recommendations that you all have made and how we implement some of those recommendations are critical. So our next steps will continue. The funding community is very interested in what you are outlining for your next steps because they have been looking at their funding capacity and whether your funding needs will be coming to them for additional fund dollars that they can include in their plans for funds for the next year. And I know there was also at least one conversation about additional research partnerships between this task force and maybe some research institutions outside the state. So those are just a couple of things that are being considered, and some of the activities will require full-time staff because everyone that is a member of this task force has a full-time job doing something else. So that is also a part of the funding proposal that would have to go to the initial funders as well as additional funders that have expressed an interest. I know that the Pennington Foundation sent out a letter to their funding community and let them know that one of the things they had funded included the Health Equity Task Force and some of the projects that had come out of the task force thus far. So they are looking to additional sources of funding for their next round of funding as well. So with that, I will turn it back to Drs. Brown and LaVeist, but know that the work will continue. And thank you for everything that you have done thus far and continue to do.
Thank you, Secretary Robinson. Dr. LaVeist, how do you feel about that? Our work is not done.
Well, given that we've defined our work as coming out of this pandemic and not going back to normal, but rather going forward to a better normal, I would hope that our work would not be done because I don't think we've achieved that quite yet. But I look forward to the subcommittees and future meetings where we'll talk about what we'll be doing going forward and how we'll continue to move the state towards having health equity.
Thank you. Dr. LaVeist and I just met for the first time, a little over 2 weeks ago, but we've been Zoom meeting 2 and 3 times a week. And it certainly has been a pleasure. We will continue with our journey moving forward. We will put together some strategies for next steps. We want the subcommittee members who are engaging in the deliverables that have yet to be completed to continue moving forward. And we will continue with this very important work. The governor has signed off, but I remember something he said at one of our very first press conferences when he introduced the work of the task force. And he said that the Lord's Prayer begins with the words, "Our Father." And so that makes us all brothers and sisters, regardless of systemic inequity. And I think that that is something that resonates with everyone on this task force. The work that you've done, the commitment you've shown in improving health disparities for our citizens in Louisiana is so greatly appreciated. So we will put our heads together. We will come up with next steps. We will look at where we are. And we appreciate you, Secretary Robinson, the governor, for taking the time out to reading our recommendations and to really putting forth a concerted effort in taking action, because this task force was set up as a call for action. So we thank you. Are there any public comment? Okay. There's one public comment, COVID inequity of healthcare in addition to societal anguish requires behavioral health, looking at behavioral health and the productivity and ability to care for others. And so we're recognizing that. One of the recommendations that came out of the donors that we'll probably be taking a look at is as it relates to cost and point of care cost and the impact of cost, healthcare costs as it relates to COVID-19. So that's something that was not in our original platform as a priority, but it's something that as this COVID pandemic continues is placing a grave impact on our citizens. So that may be something that we will be looking at. Are there any comments, questions before we sign off on today? Okay, well, thank you very much. We will not be meeting next week. We will notify you once Dr. Levice and I have met as to what those next steps are and present it before the task force. So stay safe, stay healthy, mask up, and let's all move forward with our initiative. Thank you so much.
Thank you.
Thanks, Dr. Brown.
Thank you.